Hi guys, yeah, thank you very much. Echoing the comments of everyone else, just absolutely gutted not to be able to be back up in Sheffield, my spiritual home, where I trained, and to see all you guys. So, and also, like I say, what wonderful talks this morning already. Really enjoyed Mary's talk first thing. Actually, that was really helpful for me, and the others. Well done, guys. Yeah, I'm from Plymouth. I'm Chris Briggs. I'm HBB surgeon down there, and I do a bit of sarcoma as well. And I'm going to talk to you about a really exciting topic of chronic pancreatitis surgery, which Gavin touched on this morning. And yeah, that really made me quite nervous about doing my talk because he gave a wonderful presentation about minimally invasive approaches. But I'm hoping to try and persuade you that I'm not completely lost in this. So I'm going to talk, sorry, my declarations, I haven't got anything to talk about there. I'm going to talk about selecting a patient for surgery, what operation should we do, and more importantly, what about timing? And I'm going to highlight three papers which I think have changed my approach towards this and hopefully might change your ideas about the surgeon being involved with these patients. So it's always good to have a definition in chronic in illness, and here we are, the nice guidance on chronic pancreatitis. And most importantly for me, you'll notice that morphology isn't actually mentioned in this definition, but for me as a surgeon, and for whenever we're thinking about intervening in chronic pancreatitis, the morphology of the gland is really important. So what I'm looking for is duct dilatation and obstruction, which is the thing that interests me the most. And then obviously symptoms. The patient will have abdominal pain. If they haven't got symptoms, then intervention, as Gavin said earlier, is probably not indicated. Now, when you talk to people about chronic pancreatitis, you get them all switching off. Here's a group of very engaged surgeons all ready to get involved in a talk at a meeting previously. You'll see Mr. Peterson featuring there just next to me, my old mentor, showing me the way there. So I'd like you all to just switch on for 10 minutes now while I talk about this. So who do I want to see? Well, when I say I actually mean we. And I do really need the help of all the team here. We're talking about everybody who's spoken this morning, really, the dietitian, the gastroenterologist, the radiologist, and actually we, I think, want to see everybody with pancreatic duct obstruction, and at least initially, because what we do have to think about is cancer. That's got to be on the radar. And also, I want to assess the patient and think about addressing the cause of the chronic pancreatitis. So, and here it's stopping smoking and abstinence from alcohol. And if I just show you this kind of pie chart showing causes of chronic pancreatitis, you'll see that alcohol and smoking are massively feature in here. And then we've of course got that group which we never get to the bottom of, the idiopathics, and then a tiny fraction which are the other really rarer causes. And if I'm going to think about intervening in a patient with chronic pancreatitis, they must engage with the alcohol cessation and smoking. And we spend quite a lot of time in the clinic talking about that and involving the smoking cessation services and the GP and trying to get the patient engaged with those things. And then if they're not going to do that, I'm afraid that me intervening as a surgeon probably is not going to happen. And this kind of behaviour is very common in these patients. Once again, you see Mr. Peterson enjoying some chronic pancreatitis provoking insult here. If they're not going to stop, then I'm afraid that surgery probably is off the cards. And I suspect Gavin would say the same about his type of minimally invasive interventions. So then second in the clinic, or on the discussion at the benign NDT, portal hypertension and cirrhosis are a massive no-no for me. I'm not going to go near those patients. The outcomes are appalling. They don't benefit from having a surgeon interfere with them. And then once we get down that list, we're then into the prehabilitation phase. Once we've decided, yes, this patient might be eligible, we've got to optimize them. And that's where Mary and her colleagues come in as a really important part of our management, and our dietitian in Plymouth is really important to me because we know these patients have micronutrient deficiency, they're malnourished, they have sarcopenia, they are really not in good shape for us to go and fiddle with them. So it's nutrition, it's pancreatic enzyme therapy, It's addressing those micronutrient deficiencies. And then it's the involvement of the wider team. So a lot of these patients may have type 3C diabetes. The diabetic CNS is important, and getting good sugar control. Pain management I'm going to come on to next. And we mustn't forget about bone disease. So what about pain? Well, this is the heart sink in the clinic, discussing this with the patients. I know it's hard, but it is really important. And the type and duration of pain really is key to successful outcome. The patient's got to be motivated to stop those causes of the pancreatitis, and they have to be motivated to try and avoid, ideally avoid, or get off strong analgesics. And then we have some chronic guidelines for pain in pancreatitis that might help us. I'm just going to show you some of these. So this is the 2017 guidance, which was written. You don't try and read all of this horrible flow chart here, which you probably can't see, but there are just a couple of things I want to highlight to you. At the top, it basically says patient with pancreatic pain, and then it comes down into this box here, where Gavin, luckily, is right at the top of this chart. So once the patient's diagnosed with pain, he can consider his endoscopy and ESWL and lithotripsy, and get in there right at the beginning of all of this, which I suspect is very helpful to outcomes. Now, and on this nomogram, unfortunately, us old surgeons are all the way down here. And that's after, as you can see, multiple non-steroidals, gabapentin, seeing a psychologist, multiple episodes of follow-up, probably intervened by the endoscopist on many, many occasions. And then finally, right at the bottom, once they're on strong analgesics, they end up coming into the surgical clinic on this flow chart. And you can imagine that our outcomes probably are impacted by that. And when I'm thinking about intervening in a patient with chronic pancreatitis, I do need the help of the pain team. And that's really about setting out a plan for how we're going to withdraw analgesics, or how we're going to manage pain after intervention. And that has to be done with the patient to a lot, to try and engage them in that idea that we're aiming for off analgesics and to get good outcomes from that perspective. So why am I banging on about the duration of pain and that flow chart? Why does that upset me that I'm right at the bottom? Well, this is the first paper I'm really going to bang on about. So this is the Dutch study group who've already been talked about this morning, who do a lot of good work in pancreas. And in 2012, they looked at 260 of their patients that had undergone chronic pancreatitis surgery. And they sent out a retrospective kind of questionnaire, prospective questionnaire, if you will, looking retrospectively at pain scores and quality of life, and asked all of these patients, how are you getting on? And then they chucked it in the number grinder and did their multivariate analysis, and three things came out as being important for getting good outcomes from surgery. The first was a reported duration of pain of less than 3 years. The second was no preoperative opioid use. And the third was a minimal number of endoscopic attempts to treat it, so less than 5. If you're banging on and on with the endoscope, you're probably not going to win the battle. And actually, when I look at those three things, those are the types of patients that were coming through into the surgical clinic that had had long duration of pain, they're already on opioids, and they've already failed endoscopic management. And surprise, surprise, the outcomes weren't too great. So why is it that pain duration influences the outcome? Well, if you think about pain and chronic pain, I think we understand its etiology and the pathways that are set up. When you've got local inflammation and a problem locally within the pancreas, there are wiring problems peripherally. Those local nerves are being upset. And so a local intervention to that area can change that and can downgrade that pain. Once the duration of symptoms has gone on for a significant period of time, we know now that there is central remodeling, and the cerebral nervous system takes over. Rather than being peripheral stimulation, we're having central remodeling, and perception of pain is completely changed. And in this situation, the local interventions with surgery and probably endoscopy, once it's gone for a long time, is not going to have a good outcome on pain and analgesic requirement. So the Dutch group then said, okay, we've got these three factors that seem to be important. but we've got poor evidence. It's a retrospective study. So let's go ahead and do a randomized study. And this is the ESCAPE trial, the second paper I'm going to talk about, and just published last year, which looked at the effect of early surgery versus an endoscopy first approach. They had 88 patients and randomized them to immediate surgery within 6 weeks or a step-up endoscopy approach. And they had those very strict criteria. They must have less than 3 years diagnosis, minimal opioid use, and a dilated PD on imaging. If we go into the analysis of this, you'll see that of the 44 patients in each arm, there was a significant dropout rate of about 25%, so 11 and 12, who didn't actually get into the per protocol analysis. And that's probably because of a problem with engaging with these patients and the differing strategies within the group to manage them. Even in the surgical arm had surgery later than 6 weeks. I mean, that reflects the real world, I think, of trying to get these patients into theatre within 6 weeks is difficult, certainly would be in my practice. Some of them didn't have surgery, some of them had a different type of surgery. And across in the endoscopy arm, there were some significant protocol violations. ESWL wasn't used appropriately in a few. Multiple stenting wasn't reused, and the things that Gavin mentioned probably weren't quite adhered to. And then the other thing I wanted to draw your attention to was that 13 in the endoscopy arm actually went on and had surgery. So a significant number failed in their endoscopic approach, but they still went on and had surgery. And perhaps that is the approach that we should be thinking of. So this is what I would propose as a potential new pathway for these chronic pancreatitis with ductal obstruction. I think they should come into our chronic pancreatitis MDT and come into a joint clinic setting where they see the clinicians that we've talked about. And at that point, we decide whether or not they have no intervention, so they're not appropriate to go into treatment. They may well progress onto a trial of endotherapy, but that should be limited episodes. And surgery should be considered for all these patients earlier in the pathway than I showed you on that chronic pain pathway. So what about procedures? Well, having looked at the number of surgeons involved in this meeting, I'm not going to bang on about this too much because it would appear that a lot of gastroenterologists are involved. But really, we're talking about drainage versus a resection procedure. And this is the third trial that I'm going to mention to you is the CROPAC trial from the Lancet in 2017. They looked at resection versus parenchymal preservation techniques, which are decompressing the duct rather than big resections of the head, etc. And basically showed no difference in the quality of life and pain score outcomes for these patients. And that really persuaded, I think, most surgeons that actually drainage procedure is probably the way to go. So in terms of selecting the procedure, there are two main groups really, and I think about main duct dilatation on its own. And for this, in Plymouth, we think about a patient with a scan. This is one of our patients that we've operated on, an MRCP MIP image. You can see there main pancreatic duct dilatation coming all the way along, and then you can see the little side branches here dilated off the side. So there's a pressure effect in this duct. And we took this patient and did a Pusto procedure where we opened up the main pancreatic duct all the way along the side of the pancreas and placed a jejunal roux loop onto the side of the pancreas to facilitate good drainage of that pancreatic duct. And that's the kind of thing you would do for main duct dilatation in isolation. And then the second group of patients are those that have got mass-forming disease with calcification, and they've got significant mass in the head of the pancreas with that main duct dilatation. And here's a patient that we operated on in Plymouth. You can see a big rock stuck in the neck of the pancreas causing main duct dilatation. I'll just show you that. There we go. And as we come down and through, you think, okay, well, we can just open the side of the main duct and chip that stone out and put a loop on. But actually, when you come round into the head of the pancreas here, there's another big rock sat there with some mass effect in the head of the pancreas. And so this patient went on and had a Frey procedure, which basically opens up the side of the duct just like in the Pusto, but then comes round onto the head of the gland and we core out that inflammatory area in the head and get that stone out of the head in the Untitled process, and very similarly bring up a loop of jejunum onto the side of the pancreas. Very briefly, total pancreatectomy with auto-islets has also had some popularity in chronic pancreatitis. You'll see there I've referenced Giuseppe Garcia's study from Leicester. That group have done a lot of work in auto-islets, good international reputation. And I know in Oxford they're doing similar stuff. I think this procedure is probably best placed for those who have a failure of just a drainage procedure, and then they go on and can have the total pancreas removed, or they've got small duct disease, so a drainage procedure wouldn't be appropriate with us, and they've got chronic inflammatory change throughout the gland. It does involve the patient complying with a very complex pathway, as it's not offered in many places, so they're going to have to travel probably, and obviously it's a big procedure to undertake, and in this group of kind of ex-alcoholic smokers, it could be difficult to engage them, but Giuseppe published a really good series of 85 patients there that had done well. So in summary, where do I fit in? Where does the surgeon fit into all of this? Well, unfortunately for me, I think it would like to be at the beginning, please, not at the end. I'd like to be involved with discussions right at the start so that I'm not at the end of that pain pathway. I think that we need an MDT assessment and a multifaceted approach to these patients. They're difficult to engage initially and complicated to manage, and so we need all of our team members engaged and involved. And it does take a lot of time to do all of that, so it's difficult. And then I think that early intervention for large duct obstructive disease is the key to success, looking at those studies that I've just mentioned. Now, I'd love to put myself forward as a lone bandit, as it were, in a superb performer like this man who just goes and changes games on his own with no help from anybody else. But actually, I think I'd much prefer to be part of this team that won the World Cup with all these people pulling in the right direction. I think that's the key in all of these kind of pancreatic diseases, is that we need the whole team to help us. Thanks very much.
Thanks very much, Chris. We've just got a few questions from the audience, if that's okay. Got a question asking if e-cigarettes or vaping are a recognised cause of chronic pancreatitis.
I'll be really honest, I don't have a clue about that. I think the data around smoking is to do with the chemical irritation, isn't it? So I haven't got a clue about any data around that. Have you guys? Andy, any idea?
Yeah, I think at the moment I mean, cigarette smoking is actually worse than alcohol is the main thing, and the data's coming through now. I think is that it probably has a lesser effect, but so if you can get people onto e-cigarettes, that's fine. But the long term, obviously, it takes a number of years to come through, and the e-vaping kind of scenarios only been going on for about 2 or 3 years so far. So I think it's yet to see if it's going to have the big effect that we'd hope for. But yeah, who knows? But cigarette smoking is definitely massive and very underrated. Chris, they were talking about, there's a question coming about celiac plexus blocks and how we use them. And I don't know how you use them in Plymouth. I'm very hesitant to use them for people who don't have a long-term solution, because the effect is very short. They're a very high-risk group, usually to sedate. The data, as we see, that's a block using triamcinolone, so a steroid, so it's limited action. And I don't know if you used them much before, but we've tended to use them for helping patients' pain before surgery, for example, especially in the hereditary or familial pancreatitis patients, to help nutrition and pain beforehand. But what do you think?
Yeah, exactly that experience, Andy. I think I tried it, and we've tried it in patients with this kind of chronic condition where we are kind of a bit reluctant to intervene or operate, but it has very limited effect. It comes back again 6 months later. They're back in the clinic saying, well, that was great, can I have another one, please? And the duration of action, we've had patients, we've done 2 or 3, and the duration of action seems to get shorter and shorter. So I think it can be helpful in very, very selected group, like you say, as a bridge, but I don't think it's a long-term solution.
It is quite important for people you're planning to operate on. I know Mr. Al-Mukhtar, who's was keen to be here today as well. It puts feeding tubes, like enteral feeding, in before surgery, and as part of that, is that something that you've considered to just try and bridge people for surgical operations?
So I've got to be really honest. I think our experience in Plymouth is fairly limited of that. I think that comes down to the dietitian's advice, about nutritional status and assessment, and preoperatively feeding them. I'm sure has a place in some patients, but I think if you can optimise them as an outpatient, that's probably the ideal thing, really.
Thank you. All right, Chris. Well, look, thanks ever so much for your time. Sorry you can't be up with us today, and I hope it's sunnier in Plymouth than it is in Sheffield. But we'll let you go. So thanks very much for your time today, and I'll catch up with you soon, Chris. Okay.
Cheers, Andy. Thanks a lot, guys.
Cheers. Take care. So we're going to have a quick pause today. Quick pause now for 5 minutes. So if you want to get a coffee or have a toilet break, that'd be great. We're actually going to start the next session with Ewan Dixon, who's going to commence the next session at